Welcome, everyone. Thanks for joining us. This is the beginning of our 2022 Northwest States Trauma Conference. As many of you know, we have not been able to have this conference live for the last 2 years. It's been almost 3 years since I stood in this room looking out at you. It's been a long time. It's great to have you back. It's great to be here and have this conference again. Thank you all for coming out this evening. We have a tremendous event planned for you this evening. Traditionally, we like to kick the conference off the night before with a debate, a little bit of wine and cheese. We have brought in the top 2 debaters in the universe tonight to do this debate, 2 close friends. I was sure that I would soften them up a little bit. We went wine tasting yesterday. They saw Oregon. They've seen half of Oregon now. We drove out here. And they're both very impressed. So tonight, we're going to debate a very, very controversial topic. We're going to be talking about walking blood banks in the United States, and we have the perfect duo for this. We have an active duty colonel from the United States Army, Colonel Jennifer Gurney, who has been deployed 8 times and has participated very actively with walking blood banks. And we have Dr. Andrew Bernard, who's the Chief of Division of Acute Care Surgery from the University of Kentucky, who has been the president of the Eastern Association for the Surgery of Trauma. He's also the trauma medical director there, who has been working in a civilian hospital. And the question is, can you translate walking blood banks from the military setting to the civilian setting? So on the pro side, tonight we'll have Colonel Jennifer Gurney. Colonel Gurney is currently the chair of the Defense Committee on Trauma, and will be taking over the chair job of the Joint Trauma System underneath the Defense Health Agency. As I mentioned, Colonel Gurney has been deployed 8 times, primarily to Iraq and Afghanistan. Some of these deployments have been prolonged deployments, and Colonel Gurney has played a major role in the way the military is functioning, one of the most senior trauma surgeons left in the military at this time. So Colonel Gurney, could you start us off with the pro debate?
Thanks, Marty. That was a really nice introduction. If we're calling people experts, I hope that everyone's drank a lot of wine already, like started with the wine, because then we'll be able to convince you even more. So Marty and Elizabeth, Ed, everybody who put this together, thank you. This is obviously a big deal, and it has been great being in Oregon the past couple of days, my first time here. So I have no disclosures. I've got no financial conflicts of interest. I might be looking for some in the future. And while I don't have conflicts of interest, I do have an interest in conflicts. As Dr. Schreiber said, I've spent a lot of my time taking care of combat casualties. And the person I'm debating tonight is a gentleman and a scholar and a friend. And we both were very hungover today, thanks to Dr. Schreiber. So, you know, we're starting the day right. But Andrew Bernard is an academic, and he is really a gentleman. He's a family man. He's committed to his wife and his 2 children who are now grown up. He sets an example for people as a human, an example as a surgeon. And it's been great getting to know him. He is one of the best doctors in America. And this doesn't mean he's going to be right on anything that he says at all tonight. He's from the great state of Kentucky, where he's spent a lot of his time, actually most of his training, and he likes bourbon, as we all do. But we're going to talk about things that he's committed to. We know he's committed to his family, to his practice, to Kentucky, to bourbon, but we're going to talk about a story about being committed. A pig and a chicken are walking down the road. The chicken says, "Hey, pig, I'm interested in opening a breakfast restaurant with you." And the pig replies, well, what should we call this breakfast restaurant? And the chicken says, "How about ham and eggs?" The pig thinks about it for a moment and says, "No, thanks. I think I'd be too committed." So what we call the all-American breakfast dish, we're going to talk today or tonight about interest versus commitment, and why, if we're going to do anything like a civilian walking blood bank, just like we've done in the military, it takes extreme commitment. Now, so committed, I'm the pig, and Andrew's the chicken. He's interested. He's interested in the walking blood. I'm going to try and get everyone in this room to be pigs by the end of the night, committed to this endeavor of a civilian walking blood bank. So why? Why are we doing this? Whole blood is absolutely, especially fresh whole blood, the best product for a bleeding patient. And there needs to be contingency planning for blood shortages. We're going to talk a little bit more about it, but we saw during COVID, blood was off the shelves, and that's scary if there's going to be a mass cal or any type of disaster, or if you're the single trauma patient in a rural setting and there's no blood, right? So with a walking blood bank, you can essentially have an unlimited supply if it's planned and resourced correctly. It can be cheaper than component therapy. It doesn't require all the post-processing, and certainly more expeditious. There's huge logistical advantages, and we've seen this in the military, and this can absolutely be translated to the civilian setting. However, it's a commitment at every level, regional, community, and at the individual level. So while Dr. Bernard's going to be a formidable enemy in this, and he is one of the best doctors, I am going to convince him and you that whole blood and walking blood banks is the way to go. Now, we're not debating whether or not we should be. Tomorrow, I'm going to talk about whole blood and component therapy. This isn't a debate, should whole blood or component therapy. That debate should be over by now. People should be knowing that whole blood is better than component therapy. Marty might disagree with that. But Marty, Dr. Schreiber, is an example of commitment. So he is committed to this, and he's also committed to the walking blood bank, as he himself has also used it many times in the deployed environment. So should we establish it in the United States? Yes, it's feasible. It's acceptable, and I'm going to go through all the reasons why, and it will have better outcomes. So we're going to go through the history, the why, and the how. We're going to go through how to do it. We're going to talk about outcomes. So feasibility, 100 years, over 100 years of safety and efficacy. It was really in World War I that whole blood started to be used, and the walking blood banks were established on the battlefield. There was a Major Robertson and a Captain Robertson, a British and US soldiers, who really pushed the use of whole blood. They didn't have blood typing yet, but they were able to determine whether or not blood was going to be compatible. And when you look back at the history of whole blood, and we'll talk more about this tomorrow as well, the war and the evolution of blood and transfusion are tightly linked. These pictures here from World War II, you can see whole blood being given in a field hospital, as well as whole blood being given in the pre-hospital setting. This is safe. It's been done for 100 years. So operationalizing a walking blood bank. This is one of my favorite, if you have a chance, read about Norman Bethune, a Canadian surgeon who was a communist who was actually had to leave Canada, and during the Spanish Civil War was in Spain, and he would draw blood in Madrid, drive it out in that vehicle, and deliver blood to the front line. So an operationalized walking blood bank by one rogue Canadian surgeon. So other things about feasibility, supply mitigation. I already mentioned this at the beginning. We know that during COVID and during other times, there's nothing on the shelves, right? And if there's no blood on the shelf in your blood bank, what is the plan? What is the plan for the person who comes in who's bleeding to death? Or the 3 people who come in who aren't bleeding to death but are bleeding and need transfusion? So, we know that when we ask for a massive transfusion to the trauma bay, this is what comes. What if they've told you can't get it? What's the plan for that? So walking blood bank is our contingency. We can do this in the military in the most austere environments. These are examples of ICUs, operating rooms, and the HLS area. In a austere environment with reasonable communication, but not always great comms, we're able to organize and man and equip a walking blood bank. It doesn't just happen, though. It takes a huge amount of training. That's why you have to be committed. We have to all be pigs by the end of this. This just demonstrates some examples. It's a training commitment. And, there's a lot to be said about the simplicity of using whole blood compared to component therapy. And when you look at the military experience, this is as recent as January. The military's transfused over 10,000 units of warm, fresh whole blood. Now, most of this is actually type specific, but as we've learned from the low titer O experience with cold stored whole blood, you can also do, and it's been done plenty of times before, using low titer O for a walking blood bank. So you can see in terms of whole blood, over 10,000 units of warm, fresh whole blood from walking blood banks have been transfused. And we've just started using the cold stored low titer O whole blood, and over 1,700 units have been transfused. The logistical advantages cannot be overstated. We looked at this as soon as we fielded low titer O whole blood in Iraq. I happened to be there at the time. We started looking at it. It was adopted so easily. It was the medics, especially the pre-hospital providers and en route care medics, were using it right away because it's so much easier than doing RBCs, FFPs, and then trying to find platelets. Half the time you can't even find platelets. So the demand became much greater than the supply. And the Armed Services Blood Program really supported getting low titer O whole blood to the front lines. This just shows over a few months how it was quickly adopted. And this wasn't during a terribly high time for a lot of trauma. If there was, I suspect we would have used a lot more. So while it's logistically feasible and the benefits are tremendous, we still have to be looking at low titer O whole blood. Talking with Dr. Schreiber and other people as it's been adopted in the United States, there's different types of low titer O whole blood. Not all blood is created equal. And so we have to continue to do research and really look at prospective studies to figure out what type of products are best. And we're going to talk about the different types of products. And again, there's elegance in simplicity of using whole blood. Look at when you're using component therapy, keeping track, trying to get the ratio right, communicating with the blood bank as opposed to 1 unit of whole blood. So blood bank technicians, not necessarily blood bankers. They've got a lot of questions about whole blood, and they always bring up a lot of stuff. But you say, hey, you guys were doing this 100 years ago. But blood bank technicians, where they don't have to separate into components, and nurses love whole blood. 1 unit of blood gives you all the components that you need. It's easier to make, and it's also cheaper. So in terms of logistical benefits. So that's feasibility. Now we're going to talk about acceptability. How would this be accepted for civilian walking blood banks? Why would we give warm, fresh whole blood, and how do you organize it? So before doing that, and Marty and I have had a chance to talk a fair bit about, a lot of people don't understand that when you see red stuff, we assume it's all the same, and it's not. Low titer O whole blood is not the same as low titer O whole blood leukoreduced or non-leukoreduced. But when we look at the blood products available, these are the ones available in our deployed environment. There's RBCs, there's fresh frozen plasma, thawed plasma or liquid plasma, fresh plasma, freeze-dried plasma, cryoprecipitate, apheresis platelets, cold stored platelets, and I think we'll be hearing more about those in the coming years. I think they're a great product. And then whole blood. And whole blood can either be low titer O, cold stored whole blood, or fresh whole blood, which can be type specific or type O. Now, like I said earlier, we're not really talking about the difference between component therapy and whole blood. Hopefully people have adopted the fact that whole blood is a much better product than component therapy. With 1 unit of whole blood, you get much higher concentrations of red cells, platelets, and coagulation factors. When it's warm fresh, it's also warm, and you have way less citrate. That citrate is not good for patients. So now with types of whole blood, warm fresh is room temperature, transfused within 8 hours. Most of the military data is warm fresh whole blood, and it's not an FDA approved product. So it's not going to be studied prospectively. Not yet anyway. Cold stored whole blood can last up to 35 days. This is most of the civilian data. And like I mentioned, it is not ABO type specific. It's just low titer O. And so, over time, we've seen that the red stuff has changed. We've gone from whole blood. We went to clear fluids, thinking that was an appropriate resuscitation strategy for someone in shock, and then back to whole blood. So we essentially continue to go back to the future. And when the red stuff changes, we have to investigate. We have to continue to look. When something doesn't make sense, we have to look at it, and we have to be very judicious and have that spirit of inquiry. But from when we've looked at warm, fresh whole blood in the military environment, it absolutely improves survival. Now, this is compared to component therapy. It's compared to, and we don't have good data yet. And actually, Dr. Schreiber and I are working on a study to look at the difference between warm, fresh whole blood and low titer O whole blood in outcomes. But when warm, fresh whole blood's compared to component therapy, the survival difference is huge. And I'll tell you, actually, who in the room has transfused warm, fresh whole blood from a walking blood bank? Besides Marty and I, one other person? It's a game changer, right? It's a game changer. I remember the first time I had experience transfusing warm, fresh whole blood, 2005, in a tent in Tarin-Kowt, Afghanistan, really badly injured soldier, and bleeding, and we're trying to keep up. It was just me and the OR tech, and all of a sudden I'm like, oh my gosh, he's doing so much better. And I look up at the CRNA, I'm like, is he okay? Like, why did he stop bleeding? Like, sometimes they stop bleeding when they die, right? But he wasn't dying. He was all of a sudden doing great. And she had started transfusing warm, fresh whole blood from the walking blood bank. As a surgeon, you can tell right away, within minutes, when warm, fresh whole blood starts. It is a clinical game changer. And so when we've looked at this, we've seen 4-fold increase in survival if you transfuse warm, fresh whole blood. So the findings from multiple studies support its use for hemorrhage control as well as expanding in military and civilian trauma settings. This is an older study looking at 100 whole blood patients. You can see the survival difference in the survival curves. And then every study that's looked at it has really shown, especially in the sicker patients, lower mortality in those who receive warm, fresh whole blood. And when you think about the additional logistical advantages, it's crazy to not think that we're going to implement this in civilian settings. It is liquid gold. It's the best product that you can give a patient who's bleeding to death. So there's no better resuscitation product. However, it doesn't mean the game's over, right? We've got to still keep looking for better ways to do this. So how do you organize a walking blood bank, and what are the risks of doing this? So in the military, we have a low-risk population. We know their blood type, so this makes it easier. We used to test them every 90 days, but there's so much buy-in now for the walking blood bank that everybody, before they deploy, is going to get pre-screened to be a pre-screened donor, and that's now moved out to 1 year. So we also do transfusion transmissible disease testing as well as HLA antibodies. So when do you activate it? Our CPGs say that the FDA-approved products are preferred. However, I'll tell you, for me and for many of my colleagues, if someone is bleeding to death or has a horrible injury, we're going to activate the walking blood bank. It doesn't matter how much blood is on the shelf, because we know that it's a better product for the patient who's bleeding to death. You know, and in many places there's no platelets, so that the walking blood bank would be activated automatically with no platelets. This is the clinical practice guideline from the Joint Trauma System. And like I said, it says, what's the decision for transfusing warm, fresh whole blood and activating a walking blood bank? It's clinical, and it's because you're out of product. So clinical if the patient is in extremis and we don't think any other product will work, or if you're running lower platelets or other products. Now, when we talk about this in the pre-hospital environment, so I am not a pre-hospital provider. I have a tremendous amount of respect for pre-hospital providers, but I'm not one. I work in tents or I work in buildings. You know, I haven't had to transfuse, you know, blood care under fire. But if you're a pre-hospital provider, the first thing is not blood from a walking blood bank. It's low titer O that you carry with you, cold stored. The second option is pre-screened low titer O whole blood from a walking blood bank, then component therapy or the other things. So you might say, hey, Gurney, you're up here. Oh, I got to say one more thing. What's not in the resuscitation algorithm at all, and we're trying to, you know, get this completely out of the minds, is we're not resuscitating patients who are bleeding with salt water, because salt water is good for cooking pasta. It's not good for going into veins. So I think it's fair to say, you know, so you're up here saying that give warm, fresh whole blood from a walking blood bank, but that is not what you're saying for the pre-hospital environment. So why am I telling you that? Because in the pre-hospital environment, this is what they're in. Organizing a walking blood bank is no small task, even in a tent. But while it's been done, and the most number of blood products transfused in this environment from a walking blood bank is 8. 8 units of blood were drawn off of fighters and transfused to a dying casualty who survived, actually. But the reason that it's recommended as choice number 2 is because of the logistics of that environment. So how do you execute a walking blood bank? Organizing collection site, you really train, plan, you adhere to safety practices. This is something that is a massive commitment. So if this were going to happen in the United States, the commitment at every level, state, local, regional, and individuals, there just absolutely has to be buy-in. We test donors. This is just kind of going through how we do it. Like I said, it's a huge process. I've personally trained well over 1,000 people in how to do this. I've only been a part of one. It was when I donated blood, because I'm usually operating. So, you know, I haven't really gotten to, even though I've trained tons of them, we used to train every single week on this. I've never really been a part of one, except for one kind of random one for the patient that had to be transferred out of our hospital to get cardiac surgery. This is all outlined in all of our CPGs, the Emergency War Surgery book. We've got lots of slide decks on it. Like I said, it's incredibly resource intensive. But the benefits are huge, so it takes a commitment at all levels. With training, with rehearsal, with buy-in, with dedication, with commitment, you can get that first unit of blood within 30 minutes in the austere environment. So again, you're going to either be looking like this if you don't train, or with all the training, you want your walking blood bank process to look like this. It takes commitment. So what are the risks? Infection. The risk is low. Hemolytic reaction, that's a clerical error. That really underscores the need for training as well. and Rh alloimmunization. And when you think about the risk to women, if the woman is alive, it's a problem of a surviving thing, right? And you give some ROGAM. So when we looked at Iraq and Afghanistan, over 10,000 fresh whole blood transfusion, 1 case of Hep C transmission, 1 HTLV seroconversion, and 1 fatal case of graft versus host. That's kind of random. Maybe could have happened with component therapy as well. But again, most of these, except for the last one, are problems of the living, right? If you die from hemorrhage, you don't get to have the problem of the living. So the risk, when you look at the civilian setting with transfusion, transmissible disease testing, the risk of HIV, Hep C, and Hep B, 0.2%. 0.2% versus a greater than 20% risk of dying. So if you're going to play your odds, you want to have the capability to do a walking blood bank. So blood has shown up time after time through different conflicts. Why not in the civilian sector? Why not again? It's contingency planning. It's better for patients. It's the ultimate resuscitation fluid. We've got lots of data in the military. There's no multi-center randomized study. There's going to be some for low titer O versus component therapy. And Dr. Schreiber and I are on a team looking at fresh whole blood versus low titer O whole blood outcomes. Civilian walking blood banks are necessary for preparedness, not just for mass cows or large conflicts, but in the rural or urban setting when the blood banks are empty, or if you're somewhere and you don't have platelets. So there has to be a civilian plan. But then if you have a plan, you have to practice and rehearse it. So it is a big commitment, but it's one worth it. Think of all that we do for our patients to improve outcomes. This is one, and if we don't prepare and plan for this and decide that this is something we're going to do, it's going to come at the cost of lives lost. We know that patients with hemorrhagic shock have a high mortality. There are regional systems planning for this in San Antonio and in Mayo. They're looking at how do we organize walking blood banks. And this is from leaders like Don Jenkins, Marty's involved in this, John Holcomb. There are lots of people that are interested in really driving this because we know civilian walking blood banks will save lives. So it is the best resuscitation fluid. There's no question about it. Requires planning, contingency. It's cheaper. It's more expeditious. It has an exciting potential, but it takes commitment. So like I said, it's about being pigs or chickens. I'm trying to make you all pigs. I have donated blood. It wasn't during a trauma. It was a Turkish soldier who had a MI and coded, and we got him back and sent him to a hospital in Kabul. And he underwent cardiac surgery, and they needed type A blood. They were out of type A blood. So he was either going to die, or I was, myself and a few other, I'm type A, donated blood, and we brought it to the hospital in Kabul. Also, a little bit of commitment. This is how many boarding passes it took me to get here. I spent one night in the airport, and it took me, so I was committed to get here to tell you guys that warm, fresh whole blood and civilian walking blood banks are feasible, and you need to do it. So I am your pig. This is Dr. Bernard thinking about whether or not it's going to commit to the walking blood bank. So he is our chicken. By the end of the night, I hope you're all pigs with me. Thank you for your attention.
So very nicely done by a Colonel in the United States Army expressing her long experience taking care of combat casualties. Let's hear it now from the civilian perspective, because that's what we all do in our hospitals. Can this be done in the civilian perspective? Is it reasonable? Once again, let me introduce to you Dr. Andrew Bernard, who is a very well-known trauma surgeon, ex-president of Eastern Association of Surgery of Trauma, division chief for acute care surgery in the University of Kentucky, and the Paul A. Gurney Endowed Chair in Trauma Surgery, who has a tremendous experience in the civilian world. And it'll be very interesting to see his view of whether or not this is even feasible in a civilian setting.
Thank you, Marty. Can you all hear me okay? Well, there's just a whole lot to unpack there. Colonel Gurney, thank you for that. Thank you for that excellent talk. What I want you all to do is be objective. Let's be really careful. Let's be cerebral. Let's be objective about what's realistically appropriate and possible at this point in time. Now, you've heard from Colonel Gurney, who is a world authority on blood transfusion, particularly whole blood transfusion. You can see here in a tweet, she's referenced as an authority. She's a master surgeon. She is a master educator. She's an academic. She is a scientist, as you saw. Many of those papers were from her, either as a lead author or a contributing author. She's the distinguished recipient of the John Pryor Distinguished Service Award for military service. There are a few recipients of this. It's awarded every year by the Eastern Associates for Surgery and Trauma. She's a deserving recipient of the award from 2021. She's traveled the world. You can see her here in Ghana. As you can see what she's doing with her hands, she's basically telling everybody how this is going to go, right? She's type A in more than one way, okay? I think we all know that about her. She's been on television. This is her on TV describing her care of a soldier who lost 6 inches of trachea and survived, much due to her credit. And she's the voice of the case records of the Joint Trauma System. If you've not listened to these are on the East Trauma Cast site. I highly recommend these to you. So now you're thinking to yourself, how did this poor sucker from Kentucky end up in this situation, being thrown to the lions or the lioness, as it were, in this debate? And I think we know how this happened. Dr. Schreiber said, can you please come to Oregon? And I said, I would love to come to Oregon. And then I found out there was going to be a debate. No, but seriously, I want you to be objective. And I'm going to show you the data, and some of it's going to look familiar, but I'm hoping that I'll be able to show it to you in a little bit different way. What do people most expect? Think about this question. What do your patients most expect when they're getting a blood transfusion? I think we'd all agree that, number one, they expect safety. They expect to get a blood transfusion that's not going to harm them. And I think that that's a theme that we should focus on as we go through this. And the United States has one of the safest blood supplies in the entire world in its current standards, in the way it is currently done, which is not warm, fresh, whole blood. I'm not saying we won't get there, but currently today, that's just not part of the U.S. blood banking system, which is one of the safest in the world. A couple of definitions. You heard these from Colonel Gurney already, but I thought they were worth reiterating. Fresh whole blood here is whole blood transfused within 8 to 24 hours of collection. It's not refrigerated. May have a variety of anticoagulants in it. Historically, it is not leukodepleted. And it comes from an emergency donor panel or a walking blood bank that is pre-designated and pre-tested. As Jen said, it is not licensed or approved by the FDA. So currently it has no application currently in the United States, except on an exception from the FDA. So why are walking blood banks not ready for prime time? I'm going to answer that in a few slides here. This is a military paper from a couple of years ago. This is from a Forward Naval Hospital, Obstacles to an Effective Low Titer O Walking Blood Bank. And they say clearly in this paper, in circumstances where you will apply a walking blood bank, testing capabilities are rudimentary, can be unreliable and time-consuming, and that mass casualty situations, the situations in which you would implement this, are inherently chaotic. And those are the realities. And this paper goes on to describe 3 fundamental problems that are challenges to the walking blood bank. You need some stored blood available. You cannot wait to obtain your blood fresh. You will need some blood immediately available. Obtaining low titer donors and maintaining a roster of low titer donors can be difficult because they can be in short supply. And the training, as Jen said, is a significant burden. It takes training and retraining. So reason number one that walking blood banks are not ready for prime time is simply based upon quality assurance. Because walking blood banks, by their very nature, are small enterprises built out very quickly, it's extremely difficult to ensure an adequate level of quality assurance, what any of us would consider to be expected in today's hospitals in the United States. The second is the testing logistics. For some diseases, there is no rapid screening. So these patients need to be rapidly screened, and the rapid screens are not the same as the screening and testing that occurs at the blood center or Red Cross or wherever you would go to donate. And this does increase the risk of some types of infections. For example, West Nile, that is routinely tested in every blood center in the United States, would not be tested in this sort of circumstance. So some things can slip through. Testing ethics, arguably, currently today, it wouldn't be medically or legally acceptable to administer an inadequately screened unit of fresh whole blood, even in an emergency, unless there's absolutely no alternative available. And we can transmit viral infections. This is conceivably possible. Think about it. This is the rate of infection of individuals showing up at the blood center to say, I want to be a blood donor. Now, these aren't folks that slipped through and donated units that passed through testing, but these are individuals showing up. HIV, 1 in 100,000, Hep C, 11 in 100,000, hepatitis B, 6 in 100,000. So might some of these individuals be those who would roll up their sleeve in a walking blood bank, not undergo the same rigor of testing, and subject a patient potentially to a viral infection? Now, desperate situations call for desperate measures, right? And nobody knows desperate situations, desperate measures, and the things that Dr. Gurney or others who have served in theaters of war have seen. And I acknowledge that. However, we've all been in situations, in civilian environments, where somebody made a decision because they were stressed, they felt like the situation indicated that risk, but then later on we found out that that risk wasn't warranted. I'll give you a couple of examples. This is a paper published just a few months ago. I love the title. How did we reform our out-of-control massive transfusion protocol program? This group described how when they started their MTP program to when they implemented this quality assurance initiative to rein it in, the number of MTP activations increased tenfold. Every patient with a little bit of blood loss was getting an MTP activation, and the blood bank was thawing plasma, and all the bells were going off. Well, we know this happens, right? We build a massive transfusion protocol, and people just start activating it willy-nilly. That can increase patients' risk. If we put patients in a situation where a walking blood bank could similarly be activated by someone's haste, are we increasing patients' risk there as well? And this is from our place. This is looking at the blood refrigerator. Some of you had refrigerators of blood in your ED. We have only O pos and O neg. We don't have plasma. But that blood that's in that fridge in the ED is uncross-matched. So when you're reaching in that fridge and grabbing an uncross-matched unit, everybody in here should realize that that is not a fully cross-matched unit, and that even though it's O, it could be associated with a life-threatening hemolytic transfusion reaction in the right recipient, right? Some of those patients who are going to be lying on the stretcher in front of you in your trauma room will have minor red cell antibodies that can trigger hemolytic transfusion reaction. So we should use the fridge blood judiciously. You shouldn't be reaching in the fridge unless it's really on. Well, we started to pick up on cases where people reached in the fridge and they gave a unit of blood from the fridge that was O, uncrossed, put a patient at some risk, and then they never got another unit. Well, that was probably not an indicated red cell unit from the fridge. If they were only going to give one or two, which was 25% of the time that fridge was open, they probably could have done without. Again, another example of how, in the stress of the situation, people can make decisions that might not be worth the risk. Is a walking blood bank going to be that situation potentially? Reason number 4, supply-demand mismatch. In an emergency, we don't know how many we're going to need. So we have the potential to not get enough from our walking blood bank or get too much and waste units. So there's no guarantee that either that the panelists, the people on our roster of people who will participate, will be available when and if we call them. But if we're using blood from the blood center or the blood bank, and whatever our protocol is for repleting our blood bank when it's depleted, we have a reliable source of blood availability on a time frame that we can rely on. We know how long it takes to drive from across town or from Bend or from Portland. Reason number 5, undisclosed risk behaviors in the panelists. So yes, they may have been tested before, and yes, they agreed and signed up, but perhaps their risk behavior is something they weren't comfortable disclosing at the time that they signed up for the roster. They wanted to participate. They wanted to be on this list of heroes who agreed to be part of the walking blood bank, but they had a risk behavior that they didn't want to disclose because it would prevent them from being that person that was on the list. That's potentially possible. That could increase patients' risks. If that donor has risky behavior, then between the time they get tested and show up and get rapid testing, they could have acquired an infection that could harm a patient. That increased the risk to recipients. And those behaviors can change between the time somebody signs up and the time they actually need to donate. Reason number 7 is cost. And Dr. Gurney made that clear. This is costly. This is a big process, particularly for a smaller hospital. And that's where this is generally going to be used. That's the situation here. You're probably not going to have this situation in a bigger hospital that has plenty of capability. It's going to be in a small hospital. Reagent kits, staff to do the testing and collection, counseling the people who turn up positive for something on your testing, administrative cost of just maintaining the roster, probably make it unfeasible for most places. And shoot, hospitals run on a shoestring budget these days. This just came out a couple of weeks ago from the advisory board. 800 rural hospitals may close in the next few years. Small hospitals can't afford extra costs. So from a cost standpoint, it's probably not feasible. And reason number 8, if you do this, all the aspects of the liability. So this is you with your blood bank, activating a walking blood bank in your hospital. The risk is entirely on you, your hospital. Think about this, as opposed to it coming from the Red Cross or the regional blood center, where you can take it out of the cooler and you can be confident that it's been subjected to all the regulatory standards necessary so that you don't have to worry. Are we really ready to accept that heightened liability? But let's go back to some data that Dr. Gurney showed. Do we really know the outcomes? Do we really know that this stuff is safe? I get we've given some units, but do we know it's safe? So this is a paper published just a couple of years ago. This is an analysis of 10,000 fresh whole blood transfusions over 15 years. You saw this paper just in Jen's talk. The authors admitted the evidence quality in these 27 studies reporting these 10,000 cases was low or very low. Only one of them they considered to be of even moderate quality, only one of those papers. So these authors concluded that survival was equivalent for fresh whole blood versus non-fresh whole blood. This series of 10,000 cases may underestimate the risk events, and the caution should still be advised. And you'll see my colleague planted right there in the center of this author list, one of her many. She's an authority, I'll admit that. Further, in that same paper, only 8 studies reported any outcomes at all. 8 of those 27 reported any outcomes. No study reported transfused infections, but does that mean there weren't infections? Or does it mean there were and they just weren't detected or reported? Only 3 studies reported 30-day follow-up, and everybody else reported discharge follow-up, 24-hour follow-up, or no follow-up at all. So this is what these authors concluded in their paper. The adverse effects were probably underreported in these studies, and therefore no conclusions can be made about the relative safety of whole blood when compared to component therapy. And these are best case scenario. The individuals reporting those data, my colleague, Dr. Gurney, the best of the best. Those are the best results you're going to get. These people do this all the time, and they are soldiers, and they carry out their mission. Can we, as talented as we all are, in a bunch of little hospitals scattered across the union, achieve that same outcome? I'm not sure. And in all of our patients, most of these donors are males in their 20s. Most of the recipients are males in their 20s. And is it worth the risk to gain this product? I get this is awesome. And I could just imagine what it's like to have this religious experience of giving that. And Dr. Holcomb has described it like that. That giving warm, fresh whole blood, it's like a religious experience. I don't argue that. But do we really need this? This is from a very reputable Norwegian blood banking and transfusion and trauma group, where they reported their experience with creating a cold stored whole blood program. So different than a walking blood bank. This is their collection, refrigerate, and it's good for 21 days or 5 weeks. And their normal production time could be as short as 3 hours, they said. That was to cool it, rest it. It has to go through a resting phase, filtration, screening, proper complete screening like every unit in the United States gets, and blood typing, all that, sometimes in as quick as 3 hours and ready for use the same day. So if we can produce that as cold stored whole blood, fully tested, long shelf life, should we really be chasing fresh whole blood? So here's a report from the Joint Trauma System, about to be taken over by Dr. Gurney. The Joint Trauma System talks about what they consider to be their best and next best transfusion strategy, and they clearly say whole blood should be used first. But they also say that when whole blood's not available, component therapy is an acceptable second option. Okay, let's talk about component therapy, because component therapy is what we're all comfortable with. It currently exists in our current blood banking and hospital transfusion systems of care without any change. Can we get the products that we need to do this? We looked, it's Dr. Gurney's paper as well. We looked at this in Kentucky. We looked at how quickly, even in a rural level 4, one could get a hold of plasma. Can you get plasma to achieve that component therapy that the Joint Trauma System says is an acceptable second option? And although some of these hospitals required 45 minutes or 50 minutes to thaw plasma, half of the hospitals in Kentucky that are level 4 trauma centers can thaw plasma within 30 minutes. Meets the standard that the Joint Trauma System laid out on the last slide. And this is John Holcomb. He's another world authority. And as Jen showed, they have laid out the plan. They have developed our plan. Dr. Schreiber's on here, Dr. Gurney, Dr. Holcomb. They've written how to do this, but they've made it clear in this paper, there's really 2 scenarios here. There's the mass casualty scenario, which is conceivable, but not common. And there's the pandemic, sustained pandemic scenario. And we've seen that. Hopefully we won't see that again for another 100 years. Conceivable, I get it. But the majority of the transfusions we're all doing, the people in this room every day, are neither mass casualty and they're not pandemic. They're just a guy or a girl jacked up and exsanguinating. That's the general scenario. And can warm, fresh, whole blood be available in the amount of time that we need to meet that time scale? Well, here's the critical answer. This is the proper trial. And you can see from this proper trial, these are deaths in the proper trial. And you can see the deaths flatten out pretty quickly. Like by about 3 hours, most people who are going to exsanguinate have exsanguinated. So we've got to make this blood available quickly, warm, fresh, whole blood, maybe in Dr. Gurney's hands, maybe in a military setting, highly trained individuals, maybe an hour. In my place, we'd be a bit more like the 12 kids that were dancing around, I think, because we'd be doing it infrequently. This is Brian Cotton's work from several years ago, highlighting the fact that minutes count in a massive transfusion. Minutes. Every minute of delay in activating your massive transfusion protocol increases mortality. So whatever you're going to give, whole blood, fresh whole blood, cold stored whole blood, blood component therapy, plasma heavy, plasma forward, you better be getting it going, and every minute counts. Can we do that with warm, fresh whole blood? Probably not. And this is from that same outstanding Norwegian group. They're here in Bergen, Norway. And they showed in their series, developing their warm, fresh whole blood program, you can see how long it took for them to really begin to generate transfusible, this line right down here, transfusible warm whole blood units, and it's 6 to 8 hours. This is an experienced group, highly reputable in Norway. Is it conceivable we could do it faster? Of course. But so far, the evidence doesn't suggest that we can actually do it that quickly. And lastly, I'll finish with this, and Dr. Gurney highlighted this because she knew this was coming. These are the new guidelines from the TCCC, and TCCC lays it out simply like this: cold stored whole blood, number 1. Fresh whole blood, number 2. This was on a vote from world authorities. One of them happens to be somebody speaking at this meeting from whom you may have already heard in the last half an hour. And I believe her vote was that warm, fresh whole blood is going to be number 2 here. So this is promising, and I don't argue that. It is evolving. Warm, fresh whole blood, walking blood banks will come, but it's safety first, always. And we're not yet ready, not ready for prime time. Thank you.
Very convincing arguments from Dr. Bernard. I have to tell you, Colonel Gurney was writing feverishly at her desk over there, and I think she may have some rebuttal comments
I do.
for us.
Yes, I do.
But before she comes up to do that, let me just say I voted for fresh whole blood #1, not #2.
Can you go to right the end of my last slide? There's a video, and that's why fresh whole blood is #2. We'll just quickly watch that video. So one slide after that, and it'll play. It'll play. So this is the pre-hospital environment. This is why fresh whole blood is #2. We can answer that question first. Tactical combat casualty care starts with care under fire. This is a real video, not. Makes it hard.
PJ, you all right? Hey, we're taking fucking frags in fucking 125. PJ. Oh, he's fucking dead. Where are you? You okay? What do you need me to do, man?
So the medic gets shot. The medic shot in the arm.
Make sure you have security. Go naked.
So the reason, so we can answer the first question, or the last question first. The reason that low titer whole blood is the first choice is because how are you going to do a walking blood bank in that situation? You're just not, right? So you want to be able to reach into your bag and get the first blood thing as you move the casualty to safety. So, okay. Great arguments, like really good, really good. And I like excellent. The first thing, the Navy, of course they complained about it being hard. I mean, that's all I'm going to say about that. I mean, yeah, this is hard. We have to train a lot. We're not going to, so I have some, most of my Navy colleagues are all about, they would have dismissed that paper as well. The other paper that, that's looking at the 10,000 people, that UK study, many of them are the same group that wrote the refill article. Are you guys familiar with refill? That shows that it just came out in the last month. It shows that saline is just as good as blood. Things that make you go, like CNC Music Factory said, right? So the way that they look at it. And now that study, and I agree that warm, fresh whole blood and walking blood banks, when you're looking at just the quality, there has to be the sicker casualties. If it's a casualty that needs 1 or 2 units, it's probably not going to make that much of a difference. It's the exsanguinating patient. Now, Dr. Bernard, you spoke a lot about risk and quality assurance, and you're right. We have to be safety focused. Because as soon as you have a hemolytic transfusion reaction or something happens, people are going to say, stop, we never want to do this. That can all be mitigated by training. Again, even in so the hepatitis risk of all comers walking in was 5. The highest one was 5 in 100,000. The testing, the rapid testing, that is still not FDA approved because there's not really the demand signal for that, is 85% accurate. So you're going to bring that risk way down. And I just want to say again that safety is important, but hepatitis is a problem of the living. It's a problem of the living, right? So, but exsanguinating, you don't get to experience the problem of taking your monthly or daily, weekly hepatitis medications. You also mentioned the stress of the situation and making bad decisions. That's in any situation. I mean, you don't even need to be in a mass cal situation. It could just be one trauma patient. The trauma patient that gets the whole hospital to stop. There's 3 surgeons in the OR and people are running from the blood bank and you have people from the ICU helping the nurses. We've all seen those things. And you can, and again, to me, all those risks are mitigated by experience and by training. And so it is a commitment. And so if we're ever going to establish civilian blood banks in the United States, there has to be a steadfast commitment to it. But bottom line is it's doable. The military has shown that it's doable, and we do have some advantages. We have advantages with our donor population. In San Antonio, the way they're doing that, the Brothers in Arms program, all men, they get pre-screened regularly. Oh yeah, could someone lie on their screening sheet? Of course they could, right? But I mean, you would hope that someone who's going to donate blood, because they'll fill out an entire questionnaire, and it asks some very personal questions, extremely personal. And then, you're talking with someone. So what I've seen before, or I've heard before, I haven't really seen it, but heard that people will be reading the questionnaire and they won't answer the questions, they'll just leave, because they don't want to disclose that they've had the high-risk behaviors. So there's ways to mitigate this risk. Let's see. Oh, waste. So you mentioned that, but every unit, if it's not transfused within that 8 or 24 hours, especially if it's not transfused within 8 hours, it can go into the refrigerator. And it can last for, depending if it's CPD or CPDA, 21 or 35 days. So you don't really worry about the waste. And the expense is likely mitigated by the fact that it's expensive to separate bloods into components. It's expensive to do all the storage. So, where the upfront cost of training can be, mitigating the cost for the blood bankers aren't separating it into cryo, platelets, FFP, RBCs, so there's an advantage to that. So how does this get implemented? All solutions are local. It's not going to be a national thing, right? I mean, if you're at a rural hospital, and I really think rural hospitals are the place that has to focus on this, because the blood bank can be depleted in an hour with one major patient. It doesn't take a mass cal. Yes, that thing for civilian walking blood banks that Dr. Holcomb's the lead author on, we need a contingency plan for mass cals. I mean, look what's going on right now in Ukraine, right? I mean, at any time, we know that the world could change. We saw that. We've seen the world change in a matter of a day. So it's a contingency plan. And the local solution should start at the small hospitals. And, if the training, and it takes leadership, and is it assuming risk? It's absolutely assuming risk. If a trauma patient dies from hemorrhage in the OR, in the trauma bay, or en route, it's kind of, well, that happens. That happens, right? And nobody's looking at like, oh, what risk did you take? If the trauma patient died. So yes, it's taking risk because it's doing a therapy that's relatively novel in this country, and taking the risk and saying, they could have transfusion disease, there could be a efficacy or a quality assurance issue, but you have a live patient, right? So again, it's where we want to assume risk, and then how we risk mitigate. And I believe that it can totally be mitigated with a huge amount of training. It's a commitment, though. And I was you didn't have me. Your arguments were very good, but and if I wasn't such a zealot for whole blood, you might have had me convinced. But no, I have not. I'm still a pig, and I'm still a pig, and I still hope that everybody's pigs, and you're still the chicken, Dr. Bernard. You're just interested. You'll get there, though. Thank you.
I just have two comments. The first is the disease of the living. I'll just give you a Kentuckyism. Disease of the living. I get that in Kentucky. We would say there ain't no cure for dead. So I totally get what you're saying.
For dead, yeah.
There's not a cure for dead. There is a cure for hepatitis C. So the only other thing I'll say is just kind of a closing comment, and that is that that we owe a tremendous debt of gratitude to the individuals who brought us this far with this amount of understanding. All information, clinical information collected in situations like what you saw in that video. So the data that you saw up there, that 10,000 cases are from that sort of situation. So we owe a tremendous debt of gratitude to Dr. Gurney, Dr. Schreiber, others who've cared for our warfighters in those sort of situations. So this is about to be I'm a trauma director. My trauma center serves 1 million people or so. Marty's been the trauma director of Portland. I don't know how many of you all serve, a couple of million probably. This is about to be the trauma director for the United States military here. So we...
That's nice. That's really nice. It's making me embarrassed.
For me, it's just been a privilege to be able to share the podium and have a conversation about something really important with that colleague. So thanks a lot, Marty.
Thank you. Yeah. This fun. Questions, Marty?
So let's open this up to any questions from the audience. We have a Mobi app where you can ask questions. Don't have any questions there. Does anybody in the audience have any questions for our debaters? Question back there.
That's a great question. I mean, so I wonder, there's been.
Will you repeat the question, Jim?
Yeah, sorry, I'll repeat the question. So a really good question of how do you convince a population of people who sometimes don't even care to get vaccinated for a disease that we know has killed, 1 million Americans. So how do you convince a population that whole blood's the way to go? Again, all solutions are local. It's not going to happen at a national level. And I think, in San Antonio, there's a huge amount of buy-in for this. If you activate or if the text goes out to the Brothers in Arms group, they all show up at the donor centers. I mean, you can get whole blood. I don't know the exact time, but I know it's under 6 hours in San Antonio. So I think that, as we get more data and we show this, and then, I think we're going to do a survey with the team at Vanderbilt looking at what the attitudes are to blood transfusion. And I think we should be asking family members of patients. We should be asking patient family members, hey, would you donate blood, knowing that it was going to go to your family members? So, the military population, we're diverse, and, there's people who don't want to get vaccinated or people who have different opinions. The opinions range, they're huge. When you put the alarm out for a walking blood bank on any FOB, forward operating base, no matter what time it is, the line starts. It's organized. I mean, and they show up. I mean, Marty, you've seen this. I mean, 30, 40, 50, 60, a ton of people show up to donate. And so I think that there can be different perceptions and attitudes. And it would, again, I don't think that there's ever going to be like a quick national thing. I think it's going to be regional pockets that have buy-in, and that's going to be promulgated as people realize the benefit to this.
So let me ask the group, everybody works in a hospital. Let's say you're at work, somebody's exsanguinating, the blood bank is exhausted. How many people in the audience, if called to or asked to donate blood, how many of you would donate a unit of blood for somebody who's dying? There's the answer to your question. Everybody in the room would be willing to do it.
Yeah, John Drew, in answer to your question, I appreciate your question, but I'm EMS medical at Multnomah County, but my question is directed as the chair of the Oregon Disaster Medical Team. I'm in direct contact with all the coast of Oregon. I can guarantee you the coast have asked me about exactly this whole issue. We're going to be cut off in the Cascadia subduction zone. There's no way the blood's going to get us. They know they're going to be isolated. There's no way that they can get to us within 72 hours. So I can actually tell you that there's been active query about doing exactly this for those such situation. So I'm not putting you down, but not all of Oregon's the same as well. So I think certain parts of Oregon know that they're exposed and they'd be willing to do that.
Any other questions?
I just had a question in Ukraine right now in Russia that I just 2 days ago, I heard, maybe it's a rumor, but that Russia's actually using mobile blood banks on POWs of Ukraine. I was just wondering what the ethics is in wartime for the colonel. I guess this is.
Yeah, I mean, we don't really have great intel on that. They're using whole blood in Ukraine right now. That's new, and that's because a few people, Americans, Dr. Holcomb being one of them, went over and convinced them that they need to be using whole blood. And so nationally they are, which is, we don't have that type of government I don't know their practice in Russia. I know there's an interest, I've worked with some Russian surgeons before, and I think you have too, Marty, and there's definitely an interest in whole blood. Europe is very divided on its attitudes about whole blood in general. So, there are some countries that are still resuscitating with crystalloid. In Germany, I've deployed with, this is just through different deployments, interactions with some other NATO countries. They're so not interested in using whole blood. They just want to use component therapy. I had a chance to operate with a Czech surgeon on my last deployment, really bad liver injury. And we're in the operating room, and the Czech anesthesiologist, Czech surgeon, like, what's going on? I'm like, we gave this patient the liver was not bleeding. It was like this huge crack in the liver. There was like a little bit of blood. And I was like, this is what happens when you resuscitate with whole blood. So you don't even have to be a very good surgeon. It's just the liver stops bleeding itself, but the anesthesiologist and the surgeon were like, oh my gosh, they'd never seen this. I said, this is a zero crystalloid, only whole blood resuscitation. I mean, honestly, it is good for patients. And so, but what are they doing in Russia? I don't know, Marty, do you have any intel on that?
The interesting story I'll tell you is that during World War II, the Russians actually used whole blood from cadavers.
Yeah.
So recently dead soldiers, they used whole blood from them. Our country in World War II was the last to actually come on board with whole blood. We didn't use it until we invaded the beaches of Normandy, and it was done locally. We used low titer O whole blood, and we used fresh whole blood, but not until that point in the war, which is near the end of it. But
and it took an article in the New York Times to even get the U.S. military to change their practices.
Exactly. Yeah. Churchill went there. He was a professor from Mass General, and couldn't believe that we weren't using whole blood and reported to the New York Times because he couldn't get our military to change what they were doing. We were using primarily plasma, and we were using lyophilized plasma, which was multi-donor plasma that had hepatitis C infection, and lots of soldiers died from hepatitis C. And we haven't used lyophilized plasma since World War II. So the history is really interesting. As far as what's going on right now in the Ukraine, I really don't know.
So just to kind of segue off of the history in the World War II, the fact that it took the New York Times to convince the United States military to even start with the whole blood, why is it now that the civilian side, when it took a civilian paper to convince the military, why is the script flipped?
History repeats itself, right? I mean, like we can see it, we're going to talk a little bit about it tomorrow. But I think that we have short memories. We've got short institutional memories. And the thing that's different about now is we're able to capture a lot of this stuff in registries and write about it. But you can go back to data from World War II, the Armed Services Blood Program, which I show blood bankers all the time to get them on board with low titer whole blood. They were not interested in adopting it. They said, this is new. Why are we trying this new stuff? And you show them their publication from 1944, 1972 or something on how much low titer whole blood was transfused. So I think, how many times does history have to repeat itself? We see it not just in medicine, we see it with so many things. So, it's a great question. And if you can solve that problem, we'll all be better off, not just in medicine. I don't know what you guys think about that.
I think what happened was we had 20 years of war, and many civilian surgeons participated in that war. Either they started off in the military, became separated or retired, went into civilian practice, or in the reserve, and they learned the practice of using whole blood in theater, and they took it home. And so it was born out of necessity in wartime, and then we learned the practices from that, just like many other things. Tourniquet use. Before the wars in Iraq and Afghanistan, we didn't use tourniquets, we didn't use hemostatic dressings, and all of these things have been translated to civilian medicine, and I think it's because of the experiences that people had in theater.
And it's a good point. I mean, 20 years, we've been doing this for 20 years. And while it hasn't been like a high intensity conflict like World War II, we have been able to kind of look at things retrospectively and even prospectively and through the whole process improvement cycle. And that MIL-CIV collaboration is huge. It's something that is so important, during, and I don't know how much of you keep up with what's going on kind of with military kind of readiness now, but during wartime, we can translate lessons learned into the civilian sector. During peacetime, we really rely on the civilian sector to maintain our own proficiency when we're not, deploying all the time, taking trauma patients. So the military-civilian partnership and collaboration is it's huge. I mean, it's like every war, it's been, it's grown stronger. So hopefully we'll continue it.
Any other questions?
So I know you talked a lot about the problem of the living and how there are risks involved with fresh whole blood. But what if there was something like, along with the DNR, DNI, there was also a consent for fresh whole blood? Has that been considered as well as kind of a way to mitigate the risk involved with the fresh whole blood?
Well, even better, if you could think of a way to do pathogen reduction. So I think the really active research right now is on pathogen reduction. So there's a couple of different techniques. You can put the blood through a filter and filter out any virus or any other pathogen, or you can do it by light inactivation. And I think, a standard consent, we have people, anybody who's at risk for blood transfusion signs a consent. So one option would be to add fresh whole blood to that consent
form,
But another option would be and I think what ultimately will happen is that we'll figure out how to do pathogen reduction. And the blood will be safe no matter where it came from.
And
The hospitals are at risk for that liability as well with the fresh whole blood, but that takes a lot of the liability off if the patient is able to consent to that prior to an emergency.
I think one thing that didn't come up in this debate that's really critical is that recently there's a real risk that we will run out of blood products and have to stop giving blood to patients and let them die. And, we were approached at OHSU by ethicists who said that we need to limit the number of units of blood we gave patients so that everyone would have access to blood. And they were saying something like, you can give 6 units of blood and then you have to stop. So if the option is a blood with a very, very low risk or certain death for the patient, then I think it becomes clear that you're going to use fresh whole blood. And that's really the choice in theater. They're either going to die or get fresh whole blood. The blood's relatively safe, and it's very clear that survival is markedly increased. And the amount of complications are very small, and really only a handful of deaths are related to transfusing whole blood, whereas thousands of lives were saved. And that may happen in the civilian world as we run into situations where there's no more blood. We may not have any more platelets. Platelets are particularly bad because they only last for 5 days. So if there's no platelets and the option is let the patient die or give them fresh whole blood, it becomes pretty clear what to do.
And, you know, just to add on to that, it's a bit of a mindset too, you know, so I have never, when I did my, one of my years of fellowship was in San Francisco, and I operated on a patient who was just absolutely exsanguinating, had polytrauma, liver, heart, lung, bowel, mesentery. It was, and he was a cirrhotic, so he was bleeding like crazy, and ended up giving him like 90 units of blood. And then the next day, everyone was like, why didn't you stop? And I was like, what do you mean stop? Like, that's not something that's in my vocabulary when you're like operating on a patient. But I mean, there's a reality, you know, because I had never really been, I'd worked in civilian centers, but wasn't, you know, there for, it just didn't cross my mind that you could say, okay, after 20 units or after whatever, you stop. Because we have not, that's not been our experience in the military. We will, the patient will, you know, will die. We won't stop, the patient will stop. And so, you know, and I think that having a walking blood bank opportunity, then being limited, I can't imagine, because then it's like the question is, do you even take this patient to the OR? If you know you're going to be stopped at 10 units of blood, and it's like a massive pelvic fracture or something that you know the patient's going to need more than that, that really puts a huge, talk about an ethical challenge that it puts on the team. You know, that's a huge challenge. And the patient in San Francisco ended up surviving, and I think it was their largest volume of blood transfusion. I don't know if I'm sure there's been more since or before, but I remember kind of getting a lot of slack for that. Like, and it was just something that hadn't crossed my mind because we would never stop in the deployed environment, you know?
So let me ask now, take a poll. How many people in the audience think that we should start walking blood banks now? All right. How many people think we should not start walking blood banks now? Oh, pretty unanimous.
We're all pigs, right?
So with that, thank you all for staying late with us tonight. The conference will start tomorrow. We'll have breakfast at 07:30, and talks will start with Dr. Bernard at 0800. Thank you.